Hello, and welcome to the GI Medicine Resident Lecture Series. Today's lecture is on GERD and dyspepsia. Today we'll be reviewing three main learning objectives. One, understanding the clinical presentation and diagnostic workup for patients with GERD and dyspepsia. Two, applying red flag symptoms to appropriately triage patients who should be referred for upper endoscopy. Three, recognizing various treatment options and lifestyle modifications for those suspected of GERD or otherwise unclear secondary cause. Key points in the presentation will be highlighted with the key symbol shown here. It's important to understand the epidemiology and characteristics of dyspepsia. Dyspepsia is characterized by epigastric pain or burning that lasts for 1 or more months. Dyspepsia is something that's quite common. It's something that you can expect to see, and it has an extensive differential diagnosis. In fact, studies have demonstrated that it can occur in up to 20% of the population, although these prevalence rates differ depending on the definition being used. Now we'll discuss some of the causes and risk factors for patients. Approximately 20 to 25% of patients with dyspepsia have an underlying organic cause. There are several organic causes of dyspepsia, but we'll discuss some of the main causes here. These include peptic ulcer disease, H. pylori, medications with NSAIDs being the most common, gastric malignancy, important to keep on the differential, but uncommon in North America, and GERD. The two major causes of peptic ulcer disease are H. pylori and chronic NSAID use. There are many risk factors to consider for patients with GERD. Some common ones include obesity, pregnancy, smoking and alcohol use, and then physical malformations, so things like hernia or any diaphragm defects. Clinical features to be aware of for GERD and peptic ulcer disease. For GERD, common symptoms include retrosternal burning, regurgitation, dysphagia, odynophagia, belching, bloating, nausea, epigastric pain, extraesophageal symptoms such as cough. For peptic ulcer disease, common symptoms, when in fact symptomatic, can include similar things, so epigastric abdominal pain, belching, nausea and or vomiting, bloating, abdominal fullness. So in addition to a detailed and focused history for a patient, we'll go through some of the diagnostics and red flag symptoms to be aware of for patients. Initial lab workup can include a CBC, a CMP, lipase, and amylase. Red flag symptoms for dyspepsia that are important to be aware of include unintentional weight loss, dysphagia, odynophagia, any suspicion of GI bleed, and this can include things like unexplained iron deficiency anemia, persistent vomiting, palpable mass or any lymphadenopathy, and then family history of upper GI cancer. Now we'll implement our workup through this flow chart here to see who needs to be referred for upper endoscopy. So if we take a look at the left side of the screen first, so for patients less than 60 years old, it's reasonable to move forward with upper endoscopy if we have one or more of those red flag symptoms that we are previously mentioning that we find present in a patient. If we find a secondary cause, would go ahead and treat that cause. If for whatever reason upper endoscopy is not performed, would then go ahead and test the patient for H. pylori. And if H. pylori is present, would treat and then confirm eradication. If H. pylori is absent, would start patient on a PPI trial. For patients now moving to the right side of this flow chart who are 60 and older, it's reasonable to move forward with upper endoscopy with biopsy, and if secondary cause is found, would similarly treat. If no secondary cause is found and H. pylori is negative, would then trial a PPI. And we'll talk more specifics on PPI trials shortly. So for patients with GERD, there are some common lifestyle modifications and counseling that we can do for patients, and several have been used in clinical practice. In one systematic review of 16 randomized trials, they concluded that only weight loss and elevation of head at the end of the bed improved esophageal pH measurements and GERD symptoms. So interesting and important to keep in mind when we're counseling our patients. For treatment and monitoring of GERD, we have histamine H2 receptor antagonists, and that can be chosen for those patients with intermittent symptoms, maintenance for non-erosive reflux disease, or in addition to a PPI for control of nighttime symptoms. PPIs can be done as an empiric trial for 8 weeks in patients with typical symptoms, or after EGD confirmed any sort of erosive or non-erosive reflux disease. Below is a table that outlines treatment and monitoring for patients undergoing a PPI trial for 8 weeks. And it's broken down by the response that a patient has, any complications to be aware of or to consider, and the action or the things that we as providers should do based on response. So going through the first row, if the patient has a good response and there are no complications, it's reasonable to discontinue the PPI after this 8-week trial. If the patient has a good response, now looking at the second row, and there are important complications to consider, and some of those things can include things like significant esophagitis, Barrett's esophagus, dilated peptic stricture, it's reasonable to continue the PPI even after the 8-week trial. If there's a partial response, I think one thing to do would be to ensure the correct timing of the medication. Are they taking it the first thing in the morning on an empty stomach, 30 to 60 minutes before any sort of meal? You could also consider doing a PPI twice a day or even switching different classes of PPI. And then in the last row, if we have recurrence or no response, at that point, it would be reasonable to consider referral for further diagnostic workup. So this can be an upper endoscopy if this has not already been done, or even pH monitoring. So putting this framework together, we've first assessed with the focused history for risk factors, and we've evaluated the patient for red flag symptoms. On the left side, based on the age and presence or absence of any red flag symptoms, we can consider referral for upper endoscopy to evaluate for a secondary cause. If, looking at the right side now, an upper endoscopy is not performed, it's reasonable to test for H. pylori and treat if positive. And then finally, if a secondary cause is not found, H. pylori testing is negative, it's reasonable to trial a PPI for a period of 8 weeks. So, to summarize the key takeaways from today's lecture, we've applied a diagnostic workup and identified red flag symptoms to appropriately refer patients for upper endoscopy. We've reviewed lifestyle modifications, treatment options, and appropriate monitoring and follow-up for patients who are started on a PPI. And then lastly, this slide here are references to take a look at. Thank you for listening.